I think there was a slight error in the title, but my title actually is HIV Testing, Making the Most of the First 90, or It Takes Two to Tango. So the first rule of giving a good talk is knowing your audience. And I'd like to ask everyone in the room who has never had sex to please stand up. All right, ladies and gentlemen. I see, just finding your seat. All right. So those of you who raised your hands may require a bit of extra education about this, and I'll speak with you after the talk. So I'm going to try to cover these aspects: why, who, how, where, and when of HIV testing, which is the first 90. Why are we doing HIV testing? Well, historically, our focus has been on HIV case finding and linkage to treatment for HIV, and that's gotten a lot of attention over the years. However, the impact on prevention of new infections is often far more impactful from an epidemiologic standpoint, and I'll show you some data to support that. And I'll ask you to remember throughout this talk that every sexual transmission event is the result of sex between a person who has HIV and a person who does not have HIV. And this informs who should be prioritized. So most sexual contacts, even in high prevalence areas in Africa, occur between two people of the same HIV status. And these sexual contacts pose no risk of new infection. In other words, abstinence, condoms, treatment as prevention, PrEP, VMMC, etc., will not have an impact on HIV transmission in these sexual contacts. So it's up to us to identify the sexual dyads with different or discordant HIV status in order to allow us to appropriately focus prevention resources. Studies show, and I'll show you some more data, that HIV discordant sexual dyads, when they are jointly counseled about their results, they adopt risk reduction strategies. And this is true whether they are heterosexual couples, including casual, premarital, or cohabiting couples and polygamous couples, as well as MSM dyads. This whole thing is not a new idea. So we called it serosorting back in the mid-'80s when I was doing my residency in San Francisco. At that time, MSM, as soon as the tests were available, grouped themselves into essentially clubs so that they would have sexual intercourse only with people who had the same HIV status. And that was called serosorting. Now that explains also this colorful shirt I'm wearing, and you may have seen some of the other people from our project San Francisco here in Kigali. On the back it says HIV testing alone is okay if you only have sex with yourself. Couples testing is for the rest of us, join the crowd. When we're thinking also about people and their partners and HIV prevention, I'd like to just make mention of dreamers. These are young women aged 15 to 24 in most definitions, and I'll point out here that many of these young women are already in cohabiting unions. So if you look at the right-hand column, the ages 20 to 49, in several selected countries represented here, the majority, somewhere between half and over three-quarters, are already in a cohabiting union. But then when you look at the 15 to 19-year-olds, there are some countries like Mozambique where 38% of that young age group are already in a cohabiting union. So we need to think about dreamers when we think about joint testing. So how, then, should testing be provided? Well, demand creation is essential, with the messages not only being, if you have HIV, you can be treated, but also knowing your status and that of your partner or partners can help you prevent giving or getting HIV. One critical obstacle is that many, if not most, African adults do not know that it's possible to be in a long-term sexual relationship with somebody who has a different HIV status. And I'll show you some data about what I think is quite a shocking example in the next slide. So there are successful models for promoting and providing joint testing. We've helped many countries, and literally in every African country there's been at least 1 or 2 demonstration projects. There's a recipe. If you follow it, invariably it works. So the demonstration project in Durban, where our group from Lusaka, Zambia, assisted with training and providing couples testing, saw 907 couples, about 2/3 of whom were non-cohabiting couples, so they were boyfriend-girlfriend couples, were tested over 12 weekends in 5 clinics. The details are provided in these 2 publications that are illustrated, but the key take-home is that at pretest, 70% of the couples did not know it was possible that later in the day they might receive different results. Later in the day, 30% of the couples actually had discordant results. So this is, I think, and this was in 2013, fairly recently, in South Africa, which has been doing lots of work on HIV prevention. So there's quite a lot of work to go. So an indispensable part of how to do testing that is particularly relevant with self-testing is that people think, okay, if you test these two partners separately, they will go home, they will share their results, and they will make a plan. But what we know is that often if they are tested separately, particularly in light of an HIV positive result, they may not disclose accurately. They may fear disclosing. If they do disclose and one proves to be positive and the other negative, without counseling, many of them assume, often because they've been together for many years or have had lots of unprotected intercourse, that they are somehow immune, that either the HIV positive person is not contagious or the HIV negative person is somehow immune. So the joint counseling is essential, whether it's done with the two of them being tested together for the first time or whether one was previously tested and a counselor facilitates joint disclosure when the other comes in for testing. The other thing I'll mention is about confirmatory tests, because I saw some slides yesterday that indicated that in some situations only a screening rapid test was being used, and I would really caution against that. We, especially in clade A areas like here in Rwanda, a substantial number of screening positive determined tests, for example, or some others, proved to be negative on confirmatory testing. So, in addition, when you have indeterminate results, so either test, the screening or the confirmatory, have test results that are not too clear, or if you have discrepant results where the screening test and the confirmatory test are different. Often people will say, oh, that person's in the process of seroconverting. This is someone early in an infection. Well, that's not true. So in this paper, we show that only 5% of the people that had such results proved to be infected on follow-up testing or viral load testing. So where should HIV testing be provided? Well, we've all seen the various models, health facilities, community-based testing, home-based, mobile testing. Each of these has advantages and disadvantages. Health facilities, it's fairly easy. You have a captive audience of people who have come to you to seek either preventive or therapeutic care, and many of them are accompanied by partners, and that's an ideal opportunity to offer them testing. For those who aren't seeking health care, then community-based and mobile services can reach them. Home-based testing has had a really varied experience, I would say. Some countries have really done well with it. Others have struggled because, especially when counselors have to move great distances, it can be quite costly. So I'm going to make a particular point of maternal infection. Don't just measure it, prevent it. And this is PMTCT prong 1, so prevention of HIV infection in women of childbearing age. I would argue that antenatal clinics are a first priority for prevention of both heterosexual and perinatal HIV, and testing women without their partners is simply inadequate, given everything that we know now. We saw yesterday an estimated 30% of perinatal transmissions occur when the mother is acutely infected during pregnancy and breastfeeding. Our work in Zambia shows that if you sequence the viruses, you can confirm that 90% of the new infections acquired in pregnant women came from their husbands. So had they been tested with their husbands at the beginning of the pregnancy, that transmission to the woman might have been prevented. So instead of having the woman come in alone and then test her every time she comes for antenatal care and for infant vaccination, and then when she seroconverts say, oh, we have to protect the baby, let's think of women not just as incubators, but as people who deserve to be protected from HIV themselves. So one example of success is Rwanda in this regard. First funding from NIH to study ways of promoting and providing joint testing was in 2002. The president of the republic, President Kagame, launched a national couples testing mandate, and the proportion of partners of pregnant women who were tested increased from 10% to more than 80% in the next 5 years. Now, this was the data that was published in Lancet in 2008 by Dunkel and colleagues, showing that in the black box, the DHS data, observed data, and modeling, if you assumed that the transmission in discordant couples goes from 12% without couples testing to 3% with, which comes from observational data. That can prevent 74% of new infections in married men and 75% in married women. So this was the compelling reason to the Ministry of Health to continue to pursue this. One important thing to mention was that prior to 2008, so that first 5 years when partners were being tested in the antenatal clinic, they were not being tested together with their wives. So the women were coming in and they were being told, go home and send your husband in. So obviously the disclosure issues and so on became clear, and in 2009 CDC funded training and technical assistance for a national expansion of joint HIV testing in antenatal clinics, and by 2013 these procedures were established. Because of all of the promotions and mass media and so forth, premarital testing had also become a social norm at that point. And between those two things, at least 70% of new infections, it is estimated, have been prevented. Time and motion studies also show that testing and counseling couples together requires less time than testing them separately. So you're saving time and money, even if you don't believe in the prevention impacts. And the details are in this publication. Now, if we look at that same Lancet article and move to Lusaka, Zambia, you see that the proportion of infections that can be averted because of the nature of the epidemic there is lower, 54%, or rather 45% for men and 53% for women of infections could be averted with couples testing if you assume that you're decreasing transmission from 15 to 7%. But unlike Rwanda, it's a work in progress. The Ministry of Health and national guidelines have endorsed joint testing in antenatal clinics since 2008. They reinforced that when WHO issued guidelines promoting couples testing in 2012. The First Lady supported the initiative and launched joint testing at a national conference, and our project, through funding from the US, Canada, and the UK, have assisted 60 government clinics to test over 300,000 couples. However, there are 2.5 million couples in Zambia that still have not been jointly tested and counseled, and that is where the majority of new infections are now occurring. And unfortunately, the momentum has been lost. So this shows on the x-axis 2009 to 2015. The bars are the number of pregnant women attending antenatal care in Lusaka, the capital city, and the dark green represents the proportion whose partners were tested with them. You can see it did go up from 2009 at 2.6% to a high of 26% in 2012. But since then, it's leveled out. And in fact, it goes to 2015 there with 24.8%, but it's dropped in 2016. The same is true of the second largest city in Zambia, Ndola. 2% in 2009, up to a high of 17.8% in 2014, but it's now stalled. I'm going to talk a little bit about cost effectiveness. I am a physician, epidemiologist. I'm not an economist. I rely on my colleague, Ambassador Gordon Strebe. He was, after a long diplomatic career, the U.S. ambassador to Zambia. He is now an Emory Professor of Political Science and Economics, and he teaches African political and economic development. And what Gordon has taught me is that cost matters. I mean, all of us in this room are here because we want the best for everyone, but having aspirational goals is not the same thing as allocating limited resources in a data-driven way. Also, per capita income is important. So if you look on the left-hand column, South Africa and Botswana are quite wealthy countries with per capita incomes of $13,000 to $15,000 or $16,000. In comparison, the other four countries shown here have quite a bit less in terms of per capita income, and that, of course, translates into per capita expenditures on health. So when you think about the types of interventions that you would like to provide, this is something that can provide an essential context. So I'm going to show you some data from 172,000 or 3,000 couples that were tested in Zambian government clinics. Discordant couples prior to couples testing had an incidence of 12.6 per 100 person years, which decreased to 2.7 after couples testing, and that's a 78% reduction. Couples testing also has an impact in concordant negative couples. So they are at lower risk, 1.3 per 100 person years, but they're a much larger group. So those numbers do accrue. And they decrease to 0.5% or 0.5 per 100 person years, which is a 63% reduction. And most importantly, the cost of preventing one infection in Zambia through couples testing is only $440. So generally there's a benchmark that your cost per infection averted should not exceed your per capita income, and this is well within that number. If we look at the subset of couples who are discordant and we split them into those who were not on antiretrovirals on the day they were first tested and first learned they were discordant, the impact of couples testing is a decrease from 15.7 to 3.4 per 100 person years, or a 78% reduction. But interestingly, HIV-infected people who were on antiretrovirals but did not know that their spouses were negative, the transmission rate was 9.6 per 100 person years before, dropping to 1.6 after. So knowing you're in a discordant couple enhances the prevention impact, probably through a combination of improved adherence, condom use, et cetera. And of course, many people, especially in the latter years, when they learned they were discordant, they initiated ART. So stay tuned. We have an article in Press that models this data and shows that nationwide couples testing could avert over half of new infections in Zambia for 5% of the PEPFAR budget. I'd like to thank all of our funders, the National Institutes of Health, the CDC, the International AIDS Vaccine Initiative with USAID support, the Canadian and British governments, Wellcome Trust, EDCTP, Global Funds, and I may have forgotten some. I'd also like to give great thanks to the government's colleagues, staff, and participants from both Rwanda and Zambia, and to my lovely husband, Eric Hunter, who's had to leave this morning, for a wonderful 32, 24, and 20 years, respectively, of fruitful and fulfilling work. Thank you very much.